This is a 61-year-old gentleman with systemic hypertension and a smoker. He went to his physician for palpitation and routine investigations on his chest X-ray. You can see a large shadow on the left side of the heart, which most probably is a descending thoracic aortic aneurysm. Hence, a CT iotogram was done, which showed a saccular long descending thoracic aortic aneurysm measuring 6.5 into 6.3 with a large intramural thrombus in it. Any thoracic aneurysm more than 5.5 needs to be dealt with, and since this was 6.5, 6.3, chances of rupture is high and it needs endovascular closure. The length of the aneurysm was 104 millimeters. The diameter was 6.5 into 6.3 at the maximum expansion point, and there was a crescent-shaped thick intramural thrombus 36 mm in the aneurysm. It was 63 mm away from the left subclavian and 120 millimeter above celiac artery, giving us good landing zones above and below. So this is the CT picture of the thoracic aneurysm. You can see the saccular aneurysm bulging to the left on the greater curvature. Next. Now if you see the diameter of the aorta in the landing zone above is around 34, and the diameter of the aorta below was around 28. So if you see the access size vessels, the right common femoral is 11.4 into 11.9 and left common femoral was 11 into 10.4. Both iliacs were around 11 millimeter. So we had good sized access vessels, and we are planning to pre-close with the 3 proglide device the right common femoral access. So we have taken 3 accesses, actually 2 for the procedure. One, the anesthetist has taken the left radial access. We have taken the right femoral artery and the left femoral artery, common femoral. Both were done with ultrasound guidance. And then we had a 6 French sheath left in the left side, and a 6 French sheath was also put on the right side. 3 proglide sutures were placed in position, and now we are live for you from here onwards. Initially, first we are planning to do a coronary angiogram because previously we had a bad experience of doing a primary after a TEVAR procedure. Since he is hypertensive, 61 with evidence of atherosclerosis, we are going to do an angiogram before proceeding.
What is our plan now regarding coronary artery disease? Are we going to fix it first and then go for the endovascular, or at the end of the same procedure, or would you like to stage the procedure?
No, we would like to stage it. We would first go ahead with the endovascular procedure since we are all prepared for it. Since it's chronic coronary syndrome, patient does not have any symptom, we can deal with it at another sitting later on. So before deciding on the device selection, which I have already done by CT, we'll take a marker pigtail through the left common femoral artery access, and this marker pigtail you can see has markings for every 10 millimeter or 1 centimeter. So this will help us to measure the length of the aneurysm.
The reason why we are going into the left anterior oblique view is to open all the major branches of the arch vessel so that we can identify the landmark, proximal landmark, how many centimeter from the left subclavian artery. That is our idea now. Yeah, if you see, even in this image of the CT, the luminogram did not show any aneurysm. We can see a thrombosed aneurysm on the right side of the image where the arrow mark is seen, because the contrast is not entering the aneurysm. So we couldn't see, but we can see a small pouch, a small pouch projecting on the major curvature.
Okay. This is the place of the aneurysm. Yeah. So aneurysm will be projecting like this. We'll take another picture to see the lower landing zone.
So here we can clearly see the distal landing zone. Start ventilator.
So the distal landing zone seems to be healthy. So now we have to take a call on what size device we are going to deploy. We have good proximal neck and distal neck. We are 60 millimeters away from the subclavian artery, and so what we have decided is we are going to take a Valiant Captiva stent graft 36 diameter above, 32 millimeter above, 150 millimeter length. So since above we have 60 from the left subclavian, we'll place it some 20 to 30 millimeters after the left subclavian. So we have a 30 to 40 millimeter landing zone above. And then when we place it, the aneurysm is 100 millimeter. We'll have another 30, 40 millimeter sealing zone below also. So we have adequate sealing above and below. So the device that we have chosen is a 36 into 32 into 150 Valiant Captiva.
What we are doing now, for using a 035 Teflon wire, we are keeping a Judkins right catheter in the upper descending thoracic aorta, and to put the stiff wire to upsize the sheath size. This Amplar super stiff wire 035 exchange length 300 centimeter, right? 260, okay.
One should never take the stiff guide wire directly. You should always take it over a catheter so that you don't traumatize the thrombus in the aneurysmal segment. So this is the Valiant Captiva device we are taking. It is 36 millimeter at the origin and 32 millimeter. So it's a tapered stent so that it adjusts to the size of the aorta which is coming down in this case.
Show above. So coming back to the wire choice, since we are going to deploy it in the descending thoracic aorta, most stiffer wires are not required. Maybe Amplar super stiff wire itself is enough to track the device. Suppose if we want to deploy the device in the arch to begin with, to cross we require a better support. Hence during that time,
Show above.
and when you will use a Lunderquist wire, what are the scenarios you will use a Lunderquist wire?
Now when the device is of a much higher French, say 26, 27 French, when I need to place the landing zone in zone 0 or in the ascending aorta, then I would prefer a Lunderquist wire. It is a very stiff wire, traumatic wire, but when the support required is more, you'll have to use that wire.
And there is no big tortuosity in the abdominal aorta or iliac artery in this particular case. So
yeah.
I think this super stiff wire should
be enough. So we have removed the sheath. Now we are taking the Valiant Captiva device over the Amplacer super stiff wire. Okay. Once you are going to enter, you should wipe off the stent portion.
Now I want to see the wire at the ascending aorta. Is the wire is secured at the ascending aorta? Okay, now come back to pelvis. Yeah, just track the dilator tip. Show above. Track the dilator. Is that is okay or?
Yeah. Yeah.
So now, shall we take an injection and see where we are? Or I think it should be okay.
Yeah.
We will come to the LAO, but the position looks okay. So Dr. Arilan, you can take a call.
Yeah. So now we're going to repeat a shot. Roughly what we have seen is the figure of 8 which we see there. That is where the covered stent starts. So that should be in the junction of the arch and the descending aorta. So then we would be in the exact place. So
Maybe
that is what we have done.
Should I go a little up or?
Maybe a little up. Yeah.
So now from the subclavian, pigtail marker shows 4 markers, which means
We
almost
are
like
40 millimeters.
40 millimeter. So maybe, yeah, we should go little, I think, in.
Yeah, we'll go a little in so that we get more landing zone proximally.
So by seeing the pigtail marker, I'm adjusting in
Yeah.
such a way I'm a 20 millimeter from the.
Ah.
So the covered portion should come there. So I think we see the covered portion as the figure of 8 markers in the device. So
Yeah, 20. So
maybe I think we will take one another shot and we will take a call, and
DSA,
that
we'll
should be
take
a DSA.
shot. You have to hold this hand grip firm so that the stent doesn't move. Then you have to start unlocking this blue. So we'll start. We have to keep an eye whether the stent is moving or jumping down. So the sheath is slowly coming back. Now you see the figure of 8 has come out. We have to deploy 2 stents. So we have deployed 2 stents. The nose cap is still remaining captured. Okay, I'll deploy the third stent now. See, it jumped a little, but anyway, we have prepared for that. There are 2 ways of deploying this stent. One is you can keep up rotating this blue anti-clockwise, or you can, if you want rapid deployment, you can pull this trigger back and pull it so that it will get deployed. But we prefer to deploy it slowly. So I'll continue to. Okay. So now we are going to release the nose cone. You can observe the nose cone. It will slowly get.
Yeah, it's released.
Okay.
Store that.
Okay. Now I'll bring this gray proximal portion back.
Wire. Hold the wire, Ashish.
Okay. Now I'm going to gently pull out the pigtail at the same time looking for device migration. So the device is not moving.
Without the wire, through the curved pigtail, if it cross, I think usually it enters. You see the wire is not there, just the curved pigtail going through the device. And the curve you couldn't see. Maybe if I pass the wire, I think you can recognize the curve. This is the curve. It's very important to have a prolonged cine to see the delayed endo leak. Start breathing. So what's your comment on this?
You don't see, I mean, previously also we didn't see a sac. So, but as such now visualized, and you don't see. That outpouching is not there, and you don't see any delayed dye filling also.
Now we'll go for a distal landing zone
So
to
there
see
is
the.
no endo leak in the proximal segment. Now we will concentrate on the distal landing zone.
So we ruled out
down also.
1A endo leak. Now we are going to check the 1B endo leak.
Cell size of this stent is very large. So that area of thrombus will still be exposed, and you can still have embolism, thromboembolism phenomena. Now we have totally excluded the aneurysm and the thrombus. So patient is safe. Always patients with aneurysm, even if they have a thrombus inside the aneurysm sac, it can always migrate, come down and embolize. In the arch, it is dangerous. It will go to the neck vessels and cause stroke. But lower down in thoracic aneurysm, it will go down into the foot and cause your carpal tunnel syndrome or leg ischemia. Hence, it is always better to do a covered stent in an aneurysm.
Okay, we will address these questions later. So shall we? So in the meantime, while we are pulling out the device, we need to close this access. So should we do a dry closure by putting opposite balloon, or we will do a wet closure?
Well, since we have 3 proclides, we'll do
a wet closure, right?
Closure.
Now we are going to first downsize this 24 French into a 12 French or 14 French using these three proglides. You can see we put these proglides in order. The leftmost one to my hand, otherwise the patient rightmost right hand. This one is a 10 o'clock and this is a 2 o'clock and this is a 12 o'clock. The order is 10, 2 and 12. The same order we are going to
14,
do it.
14. Okay, now this is the important point where the groin has to be compressed well. There's a 24 French rent in the common femoral. Sheath fast.
The common femoral artery size is here almost like 9.5 to 10 millimeter. Hence, I think we can leisurely put 3 proglides. Suppose if the common femoral artery size is little lesser, what is your strategy, sir? Suppose 3 proglides are going to constrict the vessel if you feel.
Yeah.
How you are going to manage in the particular situation?
Then I would use 2 proglides and then assess for bleeding after the 2 proglides. In case it can get arrested by 2 proglides, I leave it as such, or else we can do a hybrid closure. We can put an angiosyl. Third, we can put an angiosyl if required. So then I would use 2. I mean, normally when you close with the closure devices, you have 20% narrowing of the vessel. So in a big vessel, you can accept it. In a small vessel, it might be difficult to accept. So then I would go for 2 proglides.
So first, I would like to remove the stiff wire out of this device. So Ashish, can you take a JR and bring this stiff wire out and we can exchange it to a 035 regular wire.
Large bore access, anything beyond 12 French, we call it as large bore access. One has to be very careful in large bore access because the complications are more, almost 15%. And if you land up with the complication with the access side, the morbidity and mortality of the procedure increases, even if you have done a successful endovascular procedure. The ProGlide has 2 suture threads. One is the blue and longer one, which is known as the rail suture, and the other one, white one, which is known as the non-rail suture. The blue suture is used to push the knot, and the white one is used to lock the knot. Locking of the knot should be done lastly before you are removing the sheath and wire.